the most important lecture, well actually was my first ever lecture that I presented in Saudi Arabia, and it states about sports medicine. Because over here, when you do your subspecialty, okay, you don't want to be a general doctor that I do everything, I do. You need to be sub specialized in something, doing something. So you have to be selective. Me, honestly, I'm interested in PlayStation. I'm a PlayStation player, frankly. So my father was punishing me every time that taking the PlayStation from me, which I'm doing to my son right now. Okay. The thing is, he could not stop me from playing PlayStation, so he told me, you want to do something, there is something else that you can do in your life, is sports medicine. So it was my father who guided me to sports medicine. Why? Because you have a joystick in your hand, and you have a camera on the other hand. So you have a screen, you're playing with your both hands in the knee, and it's a PlayStation. So if you consider that thing, if you're a professional PlayStation, you can be a professional in what you're doing. So this is my PlayStation. This is why I was interested in sports medicine, and this is why, and right now, honestly, not only sports medicine, I'm in a knee surgery sports medicine. طبعا you have shoulder, you have ankle, you have hip. صراحة, those territory it's a little bit tight, so it did not give me my field, so I did not go to it. I do shoulder, yes, I do ankle, yes, but I'm more professional in knee surgery. So one time, a guy, a friend of mine, he came and he wrote on my office, Abu Rukab. So I'm really happy to say that I'm a knee surgeon and I'm a sports medicine. But when you say sports medicine, what is sports medicine? It's a part of surgery, or it's a part of the medicine. It's a primary care sports medicine. There are two types of sports medicine. There are the surgeon type and there are the medical type. And medical type, they diagnose, they investigate, they give injections only, and then they send to you. But the effective people are the surgeon people. Sports medicine is a branch of medicine that deals with physical fitness, treatment, and prevention of injury. At your level right now, I'm not expecting you to treat a patient, no. You can just at least advise them, give them the advice, give them the knowledge, give them the information that you take. So our goal as sports medicine surgeons and primary care to improve body performance, recovery from injury. When you do surgery, that doesn't mean it's out your house, your career is over. No. When you do it in the proper time, in the correct time, it will be much better and the recovery will be faster. Preventing from future injury. What should we do to prevent our injuries? We are dealing with everybody. You don't need to be a professional. يعني أنت مسجل في النادي ولا أنت لاعب فريق XYZ. Okay. By the way, when you're a sports medicine, you are not allowed to say which team are you dealing with. طبعا أنا هلالي, أنا نصراوي, أنا مانشستر, أنا ريال مدريد. Those things you should not talk about it. You deal with everybody equally. I remember I was operating on one of the patients. He was من فريق الهلال. Okay, he was a professional player. Sadly, the anesthetist was عنصري نصراوي. Okay, he was really top نصراوي. He would never anesthetize this patient. His license was pulled out. You should not deal with this, okay, personal level during your treatment, it's out. We help many regular people as well as athletes. You don't have to be a professional athlete to seek sports medicine help. طبعا knee injuries, we're going to be talking about knee injuries and we're going to be talking about ankle injuries. So I'm going to be going fast because it's a long lecture. I'm going to specify in my next lecture next week what are the most important part that you have to concentrate on during your examination. Terminology: sprain, التواء. Who had a sprain in his life? Thank you. Finally, honesty in life. Okay, المرة الماضية there were no honesty. Okay, I had it dozens of times, me personally. Okay, sprain is a sudden joint twisting causing painful soft tissue. Sprain is soft tissue only. This is and bruising, التواء, bruising, swelling. We're going to talk about it right now. Ligamental tear. It's when more force is applied, the ligament may be strained to a point they are ruptured or functionless. Partial tear heals spontaneously. Complete tear needs a repair or a replacement. This is the knee. This is my first house, not my second house, because I know the knee before I know my wife. So this is my first house. This is where I live on it. and or my first wife كمان صراحة. I'm always inside it. Okay, I'm doing everything. I'm dealing with it. You don't imagine how enjoyable to go into the knee and see what's inside it. Okay, it's a small thing. Everybody has a knee. Okay, do you think you can see everything? What you're seeing right now, the medial condyle, the lateral condyle, collaterals, ACL, PCL. It is really, really nice slide that you can deal with it and see it nicely. Those are the ligaments that you have to know, each ligament, what is the function. Sadly, I had a resident, imagine, a resident, just joined me yesterday. I asked her a simple question, what's an ACL? What was the answer? Huh? هذا شيء في الركبة. Literally. And you're coming to work with a sports medicine, okay, you've been accepted, it's a residency program. I'm not asking you to do a surgery. I'm asking anatomy. What is an ACL? It's a simple ACL. So what's an ACL? What is the function of the anterior cruciate ligament?
Prevents anterior translation.
Excellent. Those are the words, those are the terminology that I enjoy listening to. It's anterior, prevents anterior translation. PCL, prevent posterior translation. Okay? It's anterior, and this is number one. This is the first function of the ACL, is anterior translation, and it is most 80 to 90%. What is the second function of the ACL?
Stability.
Thank you. 10 to 20% knee stabilizer. Okay? Okay, with rotation. So those are the things that you have to understand it and know it very well. Minimize anterior translation of the tibia. PCL, minimize posterior translation. It's simple. Okay? MCL will jump. Okay, minimize the valgus. What's the valgus and varus? You know it?
Valgus.
What's the valgus? Yalla.
It's when the knee goes outwards.
How awkward? Valgus is the kissing knee. Kissing knee. Varus, when the knees are both. We have a special lecture for deformity. I'm going to tell you about it later on, not today. Clinical presentation. I'm going to go fast because we're going to talk about it with the ACL. Key points. Those are the things that at your level you have to understand it. والله أنا ماشي. Oops, طقت الركبة. Okay. Locking, pain, and while squatting. I'm going down to pray. Suddenly my knee popped. I'm going down to. There are different things that. Those are terminology that the patients are going to tell you on the other side. Locking or pain, swelling, meniscal tear. Okay. This is the differential diagnosis. Okay. No, non-contact injury, popping and sound sensation, ACL, patellar instability. Contact injury, popping sound, come on. So those things, the terminology, okay, أنا ماشي, I'm playing soccer, suddenly I stopped, my knee popped out, gave out, swelling. Those are the things that you have to think about it. Those are special tests. We're going to talk about it, each one separate to each functionality. So this is my favorite lecture, my favorite part. Okay, anterior cruciate ligament is the place where you can enjoy your time. Anterior cruciate ligament is one of the most commonly injured ligaments worldwide. Worldwide. Yesterday I did a case. Saturday I have another case. It's every week 2 to 3 cases minimum. In one day I did 4 cases. Alhamdulillah Rabbil Alameen, and willing to do more. Okay. We are going to do a sports medicine center, which is going to be coming very soon. And this is the place that you guys has to be available someday, one day. Who's interested? I'm interested. Okay, but by the way, for the last 7 years right now, I had 2 or 3 students, Min al-Faisal, wearing your shoes, wearing your place. They joined me during the summer vacation for 4 months. One of them right now, he's in Hopkins. Other one, but they are all orthopedic surgeons. I had a female orthopedic surgeon at acceptable program right now, and she's with me as well. The beauty, what's the beauty? That I went مرة مستشفى حماد النزهة. I was operating over there. I went inside. I saw a female doctor. I didn't know her. honestly. ما شاء الله عددكم كبير. I'm not gonna know everybody. Doctor, you taught me one day, and she is in the program right now, and she's going to Jordan or somewhere to do her residency orthopedic. So this is the beauty. This is a thing that you can enjoy your life. The beauty of orthopedic per se, it's fast. It's not like internal medicine. Internal medicine, I'm going to give you a treatment for blood sugar. Am I going to be cured? No. I'm going to, okay, up, down, increase, decrease, okay. You have a fractured femur. خلاص, fix it and done. Go back home. An outcome is nice. Okay. This is what you have to choose. This is what you have to think about. Okay. What am I gonna do to keep a smile on the face on the father? Okay. جاني ولد طفل, literally. His thumb was completely dislocated. His brother was playing with him. He hit him. His finger was dislocated. Mother is crying. Father is crying. I enjoy them crying because I don't want them to hear that someone I'm reducing it. So I just put his finger back, went back in. Move your finger. Oh, it's functioning. This is the beauty of orthopedic. Okay. Approximately 150,000 injury per year. This is the statistic in US, and we are working for one here in Saudi Arabia. Female athletes are more prone to have ACL injury more than male because of the hormonal problems, and we're going to talk about it right now. As I told you, provide 85% anterior stability, prevent anterior translation of the tibia, and assist on transition tibial rotation in varus and valgus. So you see, so 85 and the other one is 10 to 15%. Okay, the beauty, I did my training in France, okay, and I'm proud of it, and this is me who's holding the knee over here, and the beauty over there that they allow you to go to the cadaver and you do the dissection. By the way, we are doing right now, and I'm allowing my students to go and do over there, to go to the anatomy lab in Princess Noura University. It's a 33 centimeter. تخيل كل هذا اختراع 3 centimeter. That's it. This lecture about 3 centimeter only. يعني هذا كبر ACL. It's a 3 centimeter that you see it from here to here, and this is what the whole هذا قطع في الرباط. Okay, this is what causes pain. This is what patient. This is the money maker. This is 3 centimeter. Okay, goes from where does it go? This is important. This lecture, this slide is important. This is the anatomy. This is your level, guys. Okay, where does it go from? What do you expect? What is LFC? Lateral femoral condyle. It goes from the lateral femoral condyle, from above to below, not from below to above. From the lateral femoral condyle to where? To the intercondylar eminence. What's an intercondylar eminence? I think I have it over here. When you look at this one, it's from the lateral. This is the lateral femoral condyle. Posteriorly, from the more accurate, from the medial border of the lateral femoral condyle, okay, to the intercondylar eminence. Here you have 2 eminence, okay? It goes in between them, anterior to the lateral meniscus. And there are 2 bundles. واحد يقول لك قطع الرباط is 1 bundle. No, it's not 1 bundle. It's 2 bundles. مثل ما كنتم شايفين هون, the blue one and the red one and the blue one. There are 2 bundles. Anterior medial bundle and anterior and posterior lateral bundle. We are more, when we are repairing, we are putting we are repairing it by 1 bundle, but in Japan, when I was over there, okay, they were repairing 2 bundles. It takes more time. The outcome was at the end the same. So we stopped doing 2 bundles, and we're doing 1 bundle right now for ACL reconstruction. Blood supply. ايش يصير blood supply geniculate artery زي اللي امس يقول لي والله مين كان يقول لي شو اسمه عن الدروب ريست الراديال why does he have drop wrist? The geniculate artery that comes from the femoral artery. It's the most important artery that supplies the ACL. When you go in with the scope, you can see the blood supply very nice. That's why when you have an ACL rupture, what's the first time to think about it? Thank you. Hemarthrosis, that's a perfect word. Okay, I was expecting you to tell me swelling, but this is the correct word. Okay, hemarthrosis, blood, the knee was going to be that big, okay, within seconds. Okay. 90%, this is very important thing, the ACL composition is a 90% of collagen, which means what? I can take your hamstring tendon and put it in my knee. I can take from his knee, but you can donate your ACL to, and your hamstring to a different. I did it once, but it's not here in Saudi Arabia, in Canada. Okay, the father doesn't, because his son is a professional athlete player, he wants to preserve his hamstring. But when you do an ACL reconstruction, we take the hamstring and we replace it. You take the hamstring from the knee and you replace. But the father, he wants to preserve the hamstring of his son, so he donates to his son. The father was in OR. I harvested the hamstring from his knee and I implanted it in his son's knee. How does it happen? How does it happen? Simply, external force factors, okay, including any play where the injury athletes coordination disrupted. Jalis, usually patient is running, or not patient, player is running and suddenly stopped, internally rotate or externally rotate. His knees stopped onto the ground, his full body rotated, so this is where the knee, the ligament get ruptured. Your knee went in two different directions. This is the external force that running and stopping suddenly causes this pain. Internal factors include lack of warming up. يلا يا شباب ننزل نلعب، شمر الثوب وننزل لعب. Okay, this is wrong. Okay, you have to warm up gradually. Warm up your muscle because to avoid the absorption on the shock on your knee. وبعدين differences in anatomy between men and women, increase in hamstring flexibility اللي عنده hyper flexibility or hyper laxity. الcoffee drinking, okay, with extra Pepsis, okay, those I'm a coffee drinker, don't worry, okay. شو اسمه النيكوتين, okay, itself cause ligamental laxity and they are more prone to have more injuries. Okay. Hormonal factors for female and variation in nerves and muscle control in position of the knee. This is the thing that you have to know about it, okay? When you jump and you land, when you jump, never ever land on hyperextended knee. I need to see your wrist, by the way, okay? Okay, when you jump and don't land on hyperextended. When you jump, and then you have always to jump with a flexion to protect your knee. This is number one. Number two, an incident that happened just in front of me. We were in Switzerland paragliding. When you jump from the mountain. So the instructor was telling us, okay, when you land, just land on your feet. I'm instructing everybody not to do it. You cannot land, you have to land, at least bend your knees, land on hyperextension. I didn't listen to him. When I landed on my bum. I went down, خلاص, I took a very bad shock on my bum, but it doesn't matter. He was insisting to land on a hyperextended knee. He was the instructor. Just in front of me, he landed and he popped his knee and he was showing off. So I'm gonna land on one knee كمان ونزل على رجل واحدة كمان, and that's what happened to him. So this thing, take care of it. Don't land on hyperextension. Number one, running. You see, when running, somebody's calling you, you twisted your knee. This will go some contact injury. ACL can happen in time. Okay, either isolation or you are running and somebody came and hit you from the back, and this is where you have an ACL injury. Anybody has an ACL injury? Operated?
Yeah, no, not yet.
Not yet. Okay. When was it?
In grade 9, it was long back. The doctor said you're too young to be operated, so.
That's wrong. We operate on young people, by the way. Are you back to sport?
Yeah.
Are you playing competitive sport?
No.
Thank you. That's the answer. How we diagnose it, or how did it happen? If I may ask you.
Injury, like a guy hit me from behind.
Thank you. But 9 years old, it's a bit too young.
Yeah, exactly.
Okay. Have you done any investigation?
No, not 9 years ago. When I was in grade 9.
Grade 9. Okay. Right. By the way, I operated on several people, and there is a special technique for young people to be operated on. You want to a guy who doesn't know how to deal with it. I think so. How do you diagnose ACL? خلاص, it's a crystal clear. 3 things. No, that's clinical examination. 3 things. What are they? Never fourth. When it happened, خلاص, رباط, 100%. What is it?
The type of injury.
Hemarthrosis?
Thank you. Number 1. Before hemarthrosis. Hemarthrosis is the last, by the way. Before. Number 1.
It's the type of injury when you see it.
Type of injury, لا, but the patient is going to tell you something. That's ugly.
Cruciating pain.
Sound, yeah, pop sound.
That's the most important. Pop. Pop. It's a pop. So if you are here, the last person in the room is going to hear. It's a huge pop. No, this is a strong ligament. It will never get there. Okay. Pop. Okay. Giving away. I heard a pop in my knee. My knee went away. You guys, my knee. Okay. As well as hemarthrosis. So 3 things. Pop, swelling, and gave out. Okay. Pain, okay, severe excruciating pain. It was really dark. I could not control it. It was excruciating pain, that the pain was to a level that I cannot control it. And immediate swelling, okay, of his knee, which is hemarthrosis. Okay, we'll talk about it later. I want to start it short. Then, when you have this thing and the patient is in pain, what should you do?
Treat pain.
Huh?
Treat the pain.
In the field.
Oh.
In the field. Now, you are the sports medicine surgeon or in the field right now. Patient is swelling. Stop. You know that he has a problem.
Make it cold.
Huh?
Ice.
That's good. But before putting the ice, الآيس بتحطه برا مش بتحطه. Now you are in the field.
Yeah.
المريض قدامك، اللاعب قدامك.
Stabilizing.
Last thing to do is stabilizing it because I don't want him to move. Okay. The thing is right now, what should you do? First thing you tell him, you're not gonna play again. Now, you have to come out. لأنه dealing with this athlete, sometimes you're dealing with stupidity sometimes that he thinks only in his foot or thinks only in the ball that he wants to play. You cannot play. You have to come out. If you play, you're gonna injure yourself more. You pull him out, which is the most difficult part, number one. After doing that, you're gonna apply ice, then you're gonna investigate, then the patient is in pain. What to do?
Pain.
Huh?
Injections of.
خلاص أعطينا pain injection, أعطينا continuous. How other than injection? You can stick a needle in his knee, accelerator. You are dealing with the situation. Suck the blood out. Oh my God, it's really nice. It's fresh blood, ready to be drank. If you're a vampire, you're gonna enjoy it. Okay. How to diagnose it right now? X-ray. What are you gonna see on X-ray?
Nothing.
Thank you. You will not see anything. Nothing. Unless if there's something I'll tell you. If I wanna fail you the exam, I will tell you what is this. Avulsion. Okay, I will talk about it in a few seconds. X-ray, they do X-ray, they don't see anything, and suddenly what do? They stabilize the knee, they put him in cast. This is a fatal mistake. Never put him. Okay, you don't see a fracture, you don't see anything, okay, don't put him in a cast, okay? Don't stabilize him. You want him to mobilize, you want him to go back to range of motion, and then to operate on him very soon. تفضل.
There's a test where we hold the
أيوة.
nails and push it like forward. If it moves, then
حبيت الكلام. Welcome. What do we call that test about now?
Lower.
Huh?
I know the test, but I don't know the.
Anterior drawer. Anterior crochet, anterior drawer. Posterior crochet, posterior drawer. It's easy. Orthopedic is easy, guys. Okay. طيب, X-ray was done. It was negative. What do we do next? MRI. Personally, I'm against MRI. Then I trust my guts more than the MRI. بس احنا the stupid insurance company, if you don't have an MRI, I will not operate on you. What you're gonna see on MRI?
Tear of connective
طبعا, you're gonna see the tail. But what is this? What is this white thing?
Blood.
Huh?
The ligaments are separated.
The ligament is separated. When the ligament gets separated, ايش بيصير? What's gonna happen? Your femoral condyle and your tibial plateau are gonna rotate. They're gonna hit each other. This is what we call bone bruise. Bone bruise, okay? The same, it's a bone bruise, but in nature you're gonna see it blue and red and green. Here you're gonna see it white on MRI. When you see this view on MRI, when you see it on the femoral condyle, on the tibial plateau, this is 100% ACL until proven otherwise. So, bone bruising occur in the ACL, medial third of the lateral femoral condyle, and the posterior third of the tibial plateau. What happened this one? This condyle, it went that way and it hit the back of the knee, and this is where the ACL tear has happened. This is a normal ACL, this is a normal PCL at the back of the knee. Okay, this is the ACL, this is the PCL. This is a ruptured ACL. You see, this is the normal looking of ACL. This is the ruptured ACL. How does it look like? And it's one of the interesting things that you're going to see. This is the test that you're talking about it. Okay, this is what we're going to see. Okay. By the way, anterior drawer test is not specific for an ACL. That's why when you are examining, when you're a sports medicine, never ever examine the injured knee first. Always examine the normal knee. See the standard or the baseline of the patient and then go to the other knee. Don't you ever, حتى in your life, you have a fracture in your left hand, examine the right hand first. See if there's any deformities. See if anything, then go to the affected hand. Never ever. You have 2 limbs, 2 knees, 2 shoulders. Always examine the normal side and then go to the other side. Okay, we have the anterior drawer test. As I told you, what's this one? What's the Lachman test? The Lachman test, it's more specific for ACL. This is you bend the knee 30 degree, as you can see over here. You bend the knee 30 degree, and suddenly you're gonna see the knee, it's moving in all directions. And the last thing, the most specific test for ACL is the pivot shift test. This is the most difficult one. It's the injury position. The patient is laying supine. You internally rotate with a valgus, and suddenly you're gonna say, it's gonna pop the knee out, and the patient might kill you. This is the anterior drawer test, and this is me performing. Yes, that's me performing an anterior drawer test. You can see the knee, how it's coming out. And this is the pivot shift test that's happening. طبعا ايام زمان ما كان في لا gloves ولا شيء. This is in 2013. And I was in Prince Mohammed bin Abdulaziz. I was the first surgeon to operate on a patient over there. So, how to approach those patients? We just mentioned it. Okay, stabilize the patient, take the patient out, examine him, apply ice. You're very well, okay? And then you can splint them for a while, take them to the hospital, tell the patient that you might need to be operated, and that's it. Hearing sprain, okay, when you have an MRI, the patient has an ACL, looks fine, intact, doesn't have any problems. What you're gonna do for him, just give him a time, chance, recover 4 weeks, then send him back to sport. If he starts telling you, doctor, I cannot control my knee, this is the time telling him that this sprain, it's Imanata. This is the ACL, it's elastic. What happened? It has been sprained, but it's still available. But look, it's stretched. When you go back to real active sport, the knee's gonna give away. Whenever it gave away, خلاص. So this is a functionless graft that has to be replaced. Okay. By the way, replacing an ACL is a piece of cake. It's 25 minutes. It's not a big deal. Okay, rest ice compression in case of hematoma, aspiration, as I told you, physiotherapy, avoid, okay, sometimes intra-articular injections for pain control and return to activity in 6 to 8 weeks, only whenever it's sprained. Okay, treatment for ligaments, هذا knee immobilizer, conservative management, هذا الhinge knee joint, وهذا fixed knee stabilizer. We don't open for repair right now. We don't open the knee. أول كانوا يفتحوا الركبة من فوق لتحت. Now it's simple to opening arthroscopically and we deal with it. Posterior, any question with ACL يا شباب? Posterior cruciate ligament. What is this injury? What do we call it?
Dashboard.
Thank you. Includes what?
Includes the knee and the hips.
Thank you. What's going to happen to the hip?
Posterior.
Thank you. Posterior dislocation with a PCL injury. Okay, that's called the dashboard injury. A history of direct blow, it's called the dashboard injury or hyperextension of the knee. Hyperextension of the knee that you are walking, you stabilize your knee, and somebody very funny came from the front and pushed your knee and your knee went backward. This is hyperextension of the knee, which is going to cause the problem. Examination with the posterior drawer, as I told you. This is how it looks like the PCL, and this is how it looks like on MRI. To evaluate, okay, stress radiography and more than 12 millimeter stress radiography. This is more specific, okay, but the diagnosis usually on MRI and clinical examination. In a treatment, you're going to be surprised. 90% of PCL injury are treated conservatively. When it's an isolated PCL injury, you don't need your PCL. You're walking, your knee goes back a little bit. You can control it by a knee stabilizer. Why? If your ACL is intact, your MCL is intact, your LCL is intact, do not operate on your PCL. It will heal spontaneously. Okay? Unless if there's an abulgent fracture, it's different. But PCL injury, usually it's treated conservatively, and unless it's multi-ligament, then we do surgery for them. What are the collateral ligaments? Huh? MCL, LCL. Middle collateral, not medial collateral. Medial collateral, lateral collateral. Okay, those are the 3 ligaments, the 2 ligaments that we have. Medial collateral ligament is composed of superficial and deep. This is the most strongest ligament in your body. MCL, that bulky, that big. The that big, and this is the most ligament affected in deformity. ليش؟ Because it's so tight, the knee gets small, and the LCL is weaker, the LCL gets stretched, and the MCL does not move. I mean, kill the MCL. It's really hard. Okay, so it shrink. That's why the patient goes in varus more than valgus. When the patient goes varus, why? Because the MCL gets shrunken. يكسر. Okay, and the LCL يتمدد, gets stretched. So this is why they have the deformity more. Depending on the position of the knee, it's a 30-degree flexion of the MCL and primary stabilizer. The MCL is thickened medial part of the capsule in addition to the tendon of semimembranosus, muscle posterior valgus force. Yani, when you're walking, it's very hard to be injured. Usually you have an MCL sprain when you're walking and you sprain your knee by mistake. This is where you have a medial side pain. It's a conservative management usually and does not cause any harm. A deep MCL is connected to the medial meniscus. هذا الميديال meniscus, a deep MCL متصل. والsuperficial MCL is the one on the top. It's really tough, it's really huge. Usually it's treated conservatively unless there is an avulsion fracture or something in it. Pain, okay, tenderness on the medial joint line, bruising in case of the complete rupture by severe valgus, we have to operate on it. In case of the associated injury, يعني لما يكون في عندك MCL with PCL, you have to operate on both. MCL with ACL, you have to operate on both as well. X-ray presents on fracture, stress view shows opening on the medial joint line. MRI diagnostic for bone, soft tissue, and details. And this is when you see when you see an MCL complete rupture. By the way, this is really tough to operate on. Okay, MCL, when you operate on, it's gets really shrunken and it's hard, so you have to put an allograft with it. Usually it's non-conservative, hinge knee joint, hinge معناتها زي المفصل. Okay, you can bend and extend your knee, but it's gonna avoid varus valgus in the knee. For 6 weeks. Reconstruction of the ligament are rarely necessary for chronic knee injury. Lateral collateral, it's more even less to be injured, but it can happen and more common than the MCL. Together with the iliotibial band, لأنه أنت في عندك بالlateral collateral في عندك posterior lateral corner كمان it's really tough to be injured. Full extension usually happen in men who has those injuries. Massive obese people, when they are walking, they walk this way. With the Trendelenburg movement, this is when you extend your LCL. It's really tough to deal with. Together with the posterior lateral complex, as I just told you right now, clinical presentation, diagnostic. You might not see anything, but when you examine them, you're going to see the knee is moving in all directions with the valve. Usually associated with avulsed fibular head. What's the most common structure here at the fibular head?
The comparer nerve.
Thank you. What will happen if it was injured?
Foot drop.
Foot drop. We said that last week, okay, or 2 days ago maybe. Okay. Foot drop. Okay, that's why when you are operating over here in this area, you have to do very good exploration. You have to see the nerve. You have to explore the nerve. Then you have to suture. لأنه accidentally by mistake, the patient came to you walking, and suddenly after the surgery, patient, and that's irreversible, sadly. Okay.
Doctor,
Now.
isolated medial collateral is conservative treatment?
لا. Yes, okay, I said, unless if it was really, it will never come isolated, number one. When it's overstretched, okay, when it's overstretched, okay, ممكن انت عندك medial كلها شو اسمه varus and can be with arthritis. So what we're going to do for him, we're going to realign the leg. I'm going to talk about it in the deformity lecture, and this will go back to its normal life. You can overstretch it, come on. But LCL will never be isolated. Combined injury, okay. This is very common, but usually common with massive athletes. Okay, these are many results, significant loss. These injuries need careful planning. Careful planning. I cannot. إذا كان عندك كل الليجمنتس ACL والMCL والPCL كله مقطوع. What do you do? What do you do first? Brainstorming. ACL. Think about
MCL.
it. Think about it.
The medial collateral.
You do the collaterals. You stabilize. Yani when you have a house, okay, you want to construct it. Do you build from inside or you start from outside? inside, outside, then go inside. Okay, so you MCL or LCL, you do them in first session. Patient will be able to move his knee with a knee brace. 6 weeks after, go back and do the ACL and the PCL at the same time, and now where you can have the good stability. But you have to tell him that it's going to be a very long journey. ACL reconstruction attempted by delayed procedures after dealing with associated injuries, such as example the MCL, rehabilitation order to get best function. PCL combined injury also follows some protocol to accept. يعني هذا الكلام كله. The complication with multi-ligament injury is adhesions. What does adhesions mean?
Fibrosis.
Thank you. Stiffness. You cannot bend your knee. That's why our goal in our life is to enhance mobilization, enhance range of movement, and avoid stabilizing the knee. That's why the patient, when you have a POP or ACL injury, do not apply cast. Please, do not apply cast. Okay, send them to physiotherapy, let them deal with their normal life, and then it will be fine بإذن الله تعالى. Osteoarthritis is secondary لأنه بيكون في عندك cartilage injury associated كمان. و ossification it's not significant in those things. أي سؤال بالligaments؟ فهمتوا؟ I'm going fast, I know. What's a meniscus?
Cartilage between bones, I guess.
Thank you. It has another word.
Meniscus.
It is a meniscus, but لا هيك شو اسمه when you jump and you land.
Shock absorption.
Thank you. Shock absorber. Those are the shock absorber. Why is the medial meniscus larger or wider actually, and the lateral meniscus is smaller and thicker?
The medial condyle and lateral.
صح. This is the anatomy, but why?
Because the medial is more weight is on the medial side.
Thank you. Now when I'm standing right now, my weight bearing is on the medial side, okay? But when I'm running and I rotate, I am rotating on the lateral side. So the rotation is on the lateral side, the weight bearing on the medial side. That's why you have osteoarthritis more on the medial side, and when you have an ACL, you have lateral meniscus injury. فهمت علي؟ So lateral meniscus injury goes with the ACL. إلا هذا مع osteoarthritis is normal and the most common to happen. We're going to talk about it right now. طيب. It's a crescent in shape. Fibrocartilaginous structures. Medial meniscus more C-shaped, as I told you. Lateral meniscus more circular. The lateral more mobile than the medial meniscus. You can see it more freely. And we have a special ligament, this is the prettiest tendon behind it. Act as door stopper, stability, lower the shock absorber, and provide additional contact with the surface. What will happen if the meniscus goes?
I know the fluid will pop.
Yeah.
Because there's like bone to bone.
What's going to happen? حيصير bone to bone, حيصير osteoarthritis. That's why we tell the patient something very important. If I go in and I operated on your medial meniscus, I'm doing a surgery, I'm saving your knee, I'm avoiding locking and catching. But on the other hand, I am increasing the osteoarthritis in your knee by 25%. When I'm operating on your lateral meniscus, I'm increasing the osteoarthritis by 10%, 10 to 15%. So those things, patient has to understand it. And this is a very important slide that you have to understand it. The menisci is divided into 3 zones. White zone, red-white zone, red zone. What does that mean? The white zone is the area that the most common area that has
Scheme.
tear. Most meniscal tear is in the white zone. Okay. A red-white zone is the second one, but whenever we have a tear in the white zone, it's a piece of cake. Just go in, chop it, and go out. A red-white zone, with red zone, you have to operate, you have to repair. And repairing it is something very easy. I did yesterday a case, we did an ACL with meniscal repair. It was very, very nice, mashallah. The vascular supply of the meniscus is a primary determinant of healing. That's why when you are repairing it, you are increasing healing. When I'm operating on a guy 40 years old with an ACL, it's different than operating with a 25 or 19 years old boy, okay? So it's different to how to operate on them and how to deal with them. Meniscal injury, tear is the most common injury in the knee, the medial meniscus. As I told you, 3 times more than the lateral meniscus. However, the lateral meniscus is with the ACL. There is increase in osteoarthritis, meniscal tear, and traumatic meniscal tear are commonly in young patients. Degenerative tear usually occur in older patients and can have incident onset. When we have the meniscus, how do they present? How do you know that it has a meniscus injury?
Chronic pain.
Chronic pain, chronic pain and sudden pain, unless if it was really very bad meniscus injury. Okay, patient, I have pain here, something in my knee, and suddenly when I have to I have to release, unlock it or pop it. Okay, so don't start dreaming هلا كل وقت أنا عندي في شيء في الركبة، ركبتي طقت معناتها عندي meniscus. No, it's not that. ركبتك طقت معناتها you have a weak muscles. Lazy boy. Okay, that's why. It's not that you have something in your knee. I'm sure after this lecture I'm gonna have dozens of people asking me, Doctor, when I'm bending my knee, it cracks. Is that a... So, trauma, pain and swelling. When is the swelling gonna happen? Immediately ACL. Immediately ACL. Next day. Or in 2-3 hours. Not on spot. On spot ACL. Okay, next few days. Okay, ليش؟ لأن البلد supply صغيرة مرة. It's not that like an ACL. So it's a simple one. Joint line pain and McMurray test will be positive. I will show it to you when you come to the clinic one day. Lachman in case of the ACL, MRI will be done. It will show you the X-ray. X-ray will be fine, normal. MRI, this is a normal menisci. This is when you see a horizontal tear in the meniscus, and this is when you go in by the scope. See the difference between MRI and scope? See my PlayStation? You see everything. This is the meniscus. This is the meniscus. See how small is it over here? How big is it over here? You go in. By the way, this is a 5-minute surgery. You go in. This is in the white zone. I'm going to go in. I'm going to chop it, stabilize the meniscus, and patient can go back to normal life within no time. Conservative management, if it was a simple intrasubstantial tear. Operative, it was having locking and catching and symptoms. Locking and catching, as I told you, arthroscopic management and remove of the fragment. Symptoms of recurrent disability. Surgery indicates whenever it's arthroscopically. This is how it looks like. Had a tear. This is after surgery. How does it look like? And this is what I did yesterday only when I sutured the meniscus. Check. It was exactly the same tear. I went in, I sutured it. Patient is back to normal life. He's home. الحمد لله رب العالمين. أي سؤال؟ أوكي يا شباب بالني. Anything. تفضل.
So you either suture it or cut it out.
That's what you understand? Okay. Depend where is the tear. If it was in the red zone or in the red-white zone, you're gonna try to repair it as much as you can. There are different techniques how to repair it. Inside out, outside in, والكلام هذا كله you don't need to understand it. Okay. But the thing is right now, age of the patient plays a role. Functionality and what's his job plays a role, as well as if he has any osteoarthritis or not. Okay. Those all plays role. Okay. It's easier for me to go in, chop it, أشيله وأخلص ولا أعمل الهم كله, because repairing it is more difficult than fixing it. So, but يعني, when you do it, it's something easy. But depending on the zone, the white zone, just go in. Don't try to repair it. Then if you repair it, it will get cut again. أي سؤال ثاني؟
When there's a tear in the ACL or in the PCL, and we want to do physical examination, we do the test. We talk about. Isn't painful يعني؟
ما حكي ايش اسمه التست؟
لسه
ما حكي جاوبك. Because I told you. Anterior drawer.
Yeah. Isn't it painful to do it يعني؟
Painful to do ايش؟
To do the examination.
لا listen, when the patient comes to see you, he comes for a reason. دكتور ركبتي ما هي ثابتة. دكتور I am لما أنزل أصلي he falls down. When I'm walking he falls down. When I cannot play sport. I'm a 25 years old man. I want to go back to sport. I cannot play sport. So he's frustrated. Okay. He wants to have a solution. يعني I operated yesterday ما شاء الله تبارك الرحمن إمام مسجد. Okay. يعني عم بيصلي كل ما عم بيصلي بيجي بده تخلع ركبته. I operated on him yesterday. He was really happy. Literally, I saw him after the surgery. He told me the first time to feel my knee stable for the last 1 year. So it's a straight, direct stabilizing, and when pain is not painful, because it's happening to you every time, every day. It's not painful to examine the patient. Vero. تفضل.
For locking, you said you unlock gently first, or if it fails then you do arthroscopy, صح? هو unlocking gently, do you mean like with surgery, or you mean just try?
Unlocking usually it's done by the patient himself.
Yeah.
Okay. ايش يصير؟ اوكي لما unlocking it for an awake patient, it's disaster. And the patient comes to you this way, his knee is locked. He cannot extend it. When he cannot extend it, what should you do right now? You try to extend it for him. If it not stop, don't do it. Take him to the OR. You will do it and you switch it and repair it for him. Don't even think of doing MRI. لأنه doing an MRI, you have to extend your knee. يا جماعة, I cannot extend my knee. So go do the surgery for him. And patient has to understand, I'm not here to hurt you, I'm here to help you. بس بعض المرضى لا أنا شوف يا دكتور شوف بوك. He tucked his and he's fine. Until I'm relieved. And he goes away. When he goes away, ايش حيصير؟ This meniscus is going out, in. What is it causing? Cartilage injury. So you're increasing the osteoarthritis in your knee. So this is what's happening to you at the same time. Vero. Because I had a case, okay, Kaman, one of my cousins, okay, he injured, he's a basketball player. He locked his knee because I was just freshly came from Canada, so nobody knows me. They know my father. My father is the big Saati. So they said, okay, and he was not available. He was in US that time, 2013 or 14. His father called my father and told me, my son, he said, go to Ma'ad, let Ma'ad do the surgery. Does he know how to operate? Does he know how to do it? Okay. Now, alhamdulillah, he's a father and he has a lot of things. Ankle sprain. Who has an ankle sprain? I had it several times. Ankle sprain is something very important that you have to do it. Okay, it usually happens in athlete and sports medicine. I think we're going to finish in 5 minutes because I'm not going to finish the whole lecture. Usually, what's the most important ligament is this ligament. What is this ligament? Anterior-talofibular. This is the talus, this is the fibula. Talofibular, anterior-talofibular ligament. You are walking, suddenly you twisted your ankle that way, your full body goes down on it, okay, forward. This is where it causes pain. Ankle sprain are the commonest, all related, more than related injuries. AFTL is the most common injury, anterior-talofibular ligament, and the CFL, calcaneofibular ligament, which is this one, calcaneofibular ligament as well. By the way, this type of surgery is one of the most interesting surgeries. It's very nice. The beauty is that you see the ligament, you see everything, you re-suture it back, and you're really enjoying when you're doing that. Sprain, commonest injury, the medial ligament, the deltoid ligament injury. The deltoid ligament are from the medial side of your ankle. Lateral, هي ال AFTL والcalcaneofibular ligament. Inversion and eversion, I'm going to show you the pictures. This is how it happens. This is the inversion when you have the AFTL and the CFL injured. When you have it opposite, when you go rarely to have your foot that way, usually you're walking and your foot goes this way. You rarely go in inversion. نعم eversion. The deltoid ligaments on the medial side are less unless there is a fracture. AFTL, as I told, is the most common mechanism of injury by plantar flexion and inversion. Physical examination shows drawer test. Anterior كمان ما في drawer. اليوم فكر بالdrawer بس. Okay, CFL, okay, calcaneofibular ligament. Second most common mechanism of injury is dorsiflexion and inversion. Physical examination and subtalar instability. PFL, posterior talofibular ligament, is the less common injury, but I want to show you twisted ankle due to unbalanced loading, ligament injury, نفس الكلام. Sometimes a bulging occur to the malleoli, bleeding into the soft tissue, hematoma, and bruising. This is the thing where you have. This is where you play an important role. Okay, I know that I'm going fast, but this is where you want to understand. When you have an ankle sprain, what should you do?
Doesn't it normally resolve spontaneously?
This is the mistake.
What did you say?
This is the mistake.
I've had several times which just goes away by itself.
But it comes back because you were not treated properly. This is the mistake. When you have an ankle sprain, what's happened? Until ankle sprain, yeah, no منديل أو شيء. I need a piece of paper somehow. I need a piece of paper. ها؟ قهوتي أنا أوكي ماشي. لا لا خلاص ماشي. That's fine. Okay, this is a ligament. It's mobile in all direction. Okay, you had an ankle sprain. What's going to happen? It's going to be the ankle sprain went that way. What happened to it? With little bit tear. Okay, it went because it went really bad. You did not stabilize your ankle. You did not do anything. You left it. So this is the sprain, and this is the tear. Okay, it's not torn. It's still functioning. I can still move, but it's going to heal that way. It will not heal this way. So please, treat soft tissue like a fracture. If you don't treat it properly, it will happen again and again and again. So that's why the ankle sprain has to be treated in a very nice way. This is how they come, with a bruise in their ankle, massive swelling, and really excruciating pain. Patient cannot mobilize, cannot walk. لأن ليش؟ المشكلة عم تتحرك بجميع الاتجاهات. Inability, swelling, bruising, painful range of motion. Look for possible associated injuries. Find it. This is how basketball players, that's why they put a lot of splints in their ankles. Anterior drawer test for examination. How X-ray will be fine unless you do a stress test. The stress test, you hold it and you do the stress test, you rotate it, and you're gonna find the pain, the opening. How to deal with it? Ice again, stabilize it for a while, but this is not the ideal treatment. When you have an ankle sprain, me personally, I highly advise, there are multiple schools that deal with different way, cast the patient, put him in cast. Don't you ever trust the patient. If you apply an air cast boot or you can, this is good, this is ideal, but they can remove it, put it back in, remove it, put it back in. Put him in cast, shut your mouth, shut it. This is my way of treatment. You don't like go to somebody else. You have to be efficient. You put him in cast for how long?
3 weeks.
Thank you. Who said 6 weeks? Oh, I said it. I said it. I thought that you're smart. Okay. 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 At 6 weeks, because I told you, fracture to heal it takes 6 weeks. Ligament to heal it takes 6 weeks. What's going to happen after 6 weeks? Thank you. أنا هيجي لك بستفيد. خربت لي وكان ما فيني شيء وكنت أمشي وكذا. So physical therapy is the most important part that you have to deal with it as well. Avoid those lazy things. Those are lazy things. Okay. Those are the lazy people who wants to go back to sport directly. I injured my ankle. Look what happened. Okay. My daughter. Okay. We went from Riyadh to Dubai to the water park over there. She was getting ready. She was only 10 or 12 years old. Okay. And suddenly she had her swimsuit, everything ready, and suddenly she slipped. Oh, well, first 5 minutes in Dubai. And we were staying for 1 week. Okay. And her ankle got swollen. What you're gonna do? You're an orthopedic doctor. You are the doctor that can save everybody. What you're gonna do?
Enjoy your stay.
No, there's something called the fiberglass cast. Okay, that's a water resistant. I applied it for her. She finished her first day for 2 days. Khalas, no more. And then I cast her for 6 weeks. No, I'm aggressive with my kids. Honestly. I think time is over. We're not going to talk about Achilles tendon. Okay, it's something very rare to happen, but it can happen. I had a case that has bilateral Achilles tendon there, and this is site of research. Okay, I have a research case right now about the Achilles tendon. Who's ever interested, just give me a call and we can deal with it later on. Who plays squash, guys? Excellent. Okay. I'm a squash player and I'm a member of the Ittihad Saudi for the squash, and we're going to start initiating some tournaments. So our first meeting is next week, inshallah. So we can talk about it later on. And Achilles tendon is the most common injury in squash players. Why?
It doesn't stop.
Thank you. The ground is rubber. خلصنا. Anything? Yeah. Thank you.